We're covering big changes for Medicare Advantage in 2026, what it means for you and your money, next.
Welcome to In Good Company, Elder Care in Your Backyard.
On today's episode, we're talking about big Medicare Advantage changes coming in 2026. About 69 million people are on Medicare, and an estimated 52 to 54% are enrolled in a Medicare Advantage plan. That's nearly 37 million people. Major shifts for 2026 have already been announced, and more may be coming. Some of these changes are unsettling, and if you're not informed, you could miss key deadlines and end up without coverage. This episode is specifically for those of you on a Medicare Advantage plan. If you're on a Medigap supplement plan, or you have VA coverage like TRICARE for Life, this doesn't apply to you. We'll cover what's happening, why it's happening, and the options you have. What is happening? Many insurers, from the largest to the smallest, are eliminating certain Medicare Advantage plans next year. We're talking hundreds of plans nationwide. Estimates right now suggest that over 1 million people on Medicare Advantage will lose their existing plans as of January the 1st, 2026. That's just under 3% of everyone on an Advantage plan who will need alternatives for 2026. And that number may creep higher as we approach year-end. A notable example, UnitedHealth Group, the largest insurer in the country, recently announced it will exit plans serving more than 600,000 members, primarily in less managed products such as PPO offerings. United also said it will take similar approaches in Medicare Supplement, Group Medicare Advantage for employer groups, and standalone Part D pricing next year. Quick refresher, PPO stands for Preferred Provider Organization. PPOs typically offer more flexibility to see more providers and facilities, and they do often include some out-of-network coverage, so you're not stuck paying everything if you go outside the network. That less managed products phrase refers to the fact that PPOs usually have fewer cost containment structures than HMOs, health maintenance organizations, which generally do not include out-of-network benefits and are more restrictive, so costs are more contained for insurers. It's not only PPOs going away, some HMOs will be eliminated too, but United appears focused on reducing more PPO offerings. And it's not just United. Similar moves are happening across the country with many insurers heading into 2026. Now, think like an insurer for a moment. They may eliminate specific plans, but they don't want to lose out on federal dollars tied to covering people like you. If you currently have an Advantage plan with an insurer that is discontinuing it, you will need to proactively switch to a new plan this year between October 15th and December the 31st. Those dates may sound a bit different from the timelines you're used to, and that's on purpose here. The insurer ending your Advantage plan will not crosswalk you to a new plan. A crosswalk is an automatic move from your ending plan to a new one, with little to no action required on your part. That is not what's happening. Even if they might like to, insurers will not automatically move you from the closing plan to a replacement. Here's the consequence. If you're on an Advantage plan with drug coverage that's exiting and you do nothing, you end up with original Medicare only, no Advantage plan, no supplement, and no Part D prescription coverage. If you're affected, you'll receive multiple notices from your insurer that your plan is ending. You may also get calls encouraging you to stay with that insurer on a different plan. Be aware of what's coming and consider your options. Insurers pay brokers a commission to help people with these plans. If an insurer can bypass a broker, it increases the insurer's profit margin. If you prefer not to use an agent or a broker, that's your choice. If you do rely on one, plan to reach out once the annual enrollment period begins. If you appreciate having a broker compare plans and advocate on your behalf with the insurer, contact them during the appropriate window. If you don't have an agent, we'll share tips in a moment. One caution here. If you call the number on a TV ad, respond to a telemarketer, or enroll directly with an insurer, you may change the agent or broker of record. That change can prevent your existing agent from helping you with the new plan you choose via a call center or direct enrollment. Many people don't realize that a single call can remove their broker from being able to assist. If you value that relationship, work through your broker. If you don't, now you know how that relationship ends. Also, watch for plan design changes insurers may use to contain costs. Some plans may begin requiring referrals from a primary care provider before you can see a specialist. Some insurers are partnering with specific hospital systems, which can mean your primary care physician must be within that system, or you'll need to switch. You may see more encouragement for in-home health reviews. Some plans may add a medical deductible for certain surgeries. Formerly $0 premium advantage plans may start charging a premium, and existing premiums may rise. As overall healthcare costs rise, these are subtle ways to shift or manage costs within plan structures. And it's not only about pruning products. Some insurers are exiting the Medicare Advantage market entirely because they're losing too much money, and they won't replace the removed plans with new Advantage offerings. Why is it happening? Medicare Advantage plans replace original Medicare. Instead of the government program being your hospital and medical insurance, a private insurer offering an Advantage plan becomes your insurer. Advantage plans often bundle Part D drug coverage and add varying levels of dental, vision, and hearing, plus perks like gym memberships, rides to doctor visits, and more. They aren't doing this out of charity. Insurers receive federal payments to take on the risk, which is why many Advantage plans have no monthly premium or lower premiums than alternatives. Those payments vary by state, plan type, ratings, and other factors. For easy math, imagine an insurer receives $1,000 per member per month, $12,000 per year. There's a key metric called the medical loss ratio, MLR, the percentage of premium revenue that must be spent on medical care and activities that improve quality of care. For Medicare Advantage, at least 85% must go to those costs. That includes clinical services, prescription drugs, quality improvement, perks like dental, vision, hearing, and gym, and even direct benefits like reduced Part B premiums or OTC allowances. Using the $12,000 example, at least $10,200 must be spent on those items, leaving $1,800 per person per year as a buffer. Spending above that buffer is a loss to the insurer, and yes, insurers do lose money on individual members with high costs. They rely on a larger pool of healthier, lower-cost members to balance it out. That's Insurance 101. The MLR aims to ensure value, push spending toward care rather than administrative costs, and profit, and increase transparency. Over the last 3 years, 3 major forces have pushed more cost burden onto insurers. First, healthcare costs rising faster than general inflation. Second, increased frequency and intensity of care. And third, Inflation Reduction Act drug coverage changes taking full effect in 2025, which shift more prescription drug costs to insurers. There are other factors, but those are the big 3. The upshot? Many Advantage plans experience significant losses. Add the competitive bidding process. Insurers submit bids to offer Advantage plans without seeing competitors' bids. To attract enrollees, they often price tightly with thin margins. If they bid too rich, low out-of-pocket maximums, generous benefits, lots of perks, and costs surge mid-year. They can't change the plan until the next year. They must honor it. For 2025, many bids were submitted in 2024 before the full weight of those cost pressures, especially the 2025 drug changes, hit. Costs in 2025 climbed, margins evaporated, and losses mounted. Insurers can't shut off an active plan mid-year, so their recourse is to terminate that plan for the following year exactly what United has acknowledged and what others will likely do. No one's saying poor insurers. They understand the risks and sometimes make choices that frustrate everyone. But they also won't keep bleeding money when regulations allow them to adjust by turning off plans for the next year. Your options? If your plan is exiting, it's a hassle, but it can also be an opportunity. You do have options. Option 1. Choose a new Medicare Advantage plan, either from the same insurer or a different one. Some people prefer Advantage over supplements. Some can't afford a supplement and therefore look for another Advantage plan. Work with a trusted agent or broker if you use one. Your deadline is unique if your plan is eliminated. Normally, the annual enrollment period, AEP, runs from October the 15th through December the 7th, with changes effective on January the 1st. If your Advantage plan is not eliminated, just changed, your window is still October 15th to December 7th. However, if your Advantage plan is eliminated, you have until December 31st to elect a new Advantage plan that's effective January 1st. We're not suggesting you wait until December 31st, but if you can, consider tackling this either early or between December 7th and December 31st to free up agent capacity for folks locked into the December 7th deadline. If you fail to act by December 31st, you'll begin January 1st with original Medicare only. No cap on the risk exposure under original Medicare and no Part D coverage. You can still get on a plan after December 31st, but you'll have a coverage gap, which isn't ideal. Option 2. Use your guaranteed issue GI rights to return to original Medicare and get a Medigap supplement plan with no medical underwriting. Typically, outside special windows, moving from Advantage back to original Medicare with a supplement requires medical underwriting, and you can be denied. But if your insurer takes away your Advantage plan, you have a GI window to enroll in certain Medigap plan letters without health questions and at the same rate as others your age, in attained age or issue age states. Important GI details. Under federal GI rules, you have the right to buy Medigap plan letters A, B, C, D, F, or G offered in your state. 2 key points. First, Plan N is not on that list. Outside your initial Medigap open enrollment, when you first start Plan B, Plan N is typically underwritten unless an insurer voluntarily allows GI into N, which is uncommon because GI windows tend to bring in higher cost members. Second, Plan F is only available if you are eligible for Medicare before January the 1st, 2020. In many states, with many insurers, if you qualify for GI and you're in that pre-2020 group, you may be required to use Plan F for GI. Same story if you moved out of your Advantage plan's service area. That often means you won't be able to pick a different letter during GI, though some states have special rules. If your state has year-round open enrollment, a birthday rule, or an anniversary rule, you could take Plan F initially via GI and then switch to a different letter, often to save money, around your birthday or plan anniversary. As a general rule, Plan F usually costs more overall than Plan G, so stepping to G later could save you. But remember, you only have these GI rights if you move to original Medicare, not if you immediately join another Advantage plan. That's why we encourage you not to rush to call your Advantage insurer the moment you get your termination notice. Pause, review your options, and decide what's best for you. Your GI window begins 60 days before your Advantage coverage ends and lasts no more than 63 days after it ends. In these pullbacks, December the 31st is typically the last active day. January 1st is the first inactive day. Your new Medigap coverage can't start until your Advantage plan ends. So to avoid gaps, your Medigap would start January the 1st. Just like with Advantage, if you want no gaps, make your changes by December the 31st, not December 7th. Be aware of the extra time, but don't let fear-based marketing rush you. Again, the December 31st exception applies only if your Advantage plan is being eliminated. Also, watch your mail. Medicare Advantage plans must send an annual notice of change, an ANOC, in September. Don't ignore it. If your plan is eliminated, you'll get additional letters confirming your plan is going away. If you work with an agent, connect during October through December. Agents and brokers can't discuss upcoming plan specifics until October the 1st, and no plan changes can be made until October 15th. Reaching out before those dates won't help much. This timing applies to folks already on Medicare and an Advantage plan. If you're new to Medicare, turning 65, or losing employer coverage, different timing applies, and you could reach out before October. Agent dilemma. A sensitive but important point about GI rights. In 34 of the 50 states, plus District of Columbia, insurers offering Medigap are not required to pay agents for helping you enroll during the specific GI window. In 17 states, some insurers do pay, or state law requires it. Even in those states, participation and amounts vary widely, from a small one-time payment, say $20 to $25, to a percentage of premium for a limited time. Why bring this up? Because it affects agent behavior and capacity. Annual enrollment is already the busiest season. Taking on a new uncompensated GI cases isn't sustainable for many agencies because of workload, liability as agent of record, and ongoing service costs. If you're in a non-compensating state, it may be hard to find an agent willing to handle a GI switch, or you might encounter agents who heavily steer you to an Advantage where compensation exists. That doesn't automatically mean ill intent. Advantage might truly fit your situation, but if you can't afford a supplement and want one, and the agent won't even discuss it, be cautious. For people with lower incomes, a supplement may be off the table, and an Advantage plan can be the better fit. Context matters. Checklist. This is a messy situation with confusing timelines. December 7th versus December the 31st. The 60-day and 63-day windows. And paperwork. To help navigate, we put a step-by-step checklist in the show notes. It covers how to compare plans and costs, the documentation you'll need to show a future Medigap insurer, and the order of operations for making these changes. If your Advantage plan included drug coverage and you switch to Medigap, remember you'll need a standalone Part D plan. Our checklist also explains how to find the lowest cost Part D option. Please share this with loved ones who may not be plugged into the updates. Many people on Advantage plans won't see this coming. Where to get help. We're not advocating or against Advantage plans today. This episode is a practical guide for those whose Advantage plans are terminating, and what's happening, why it's happening, and what you can do. Thank you so much for listening. Like and subscribe and give us a 5-star review on your favorite platform. Stay with us as we unpack what's new in healthcare right here in your backyard. If you enjoyed today's conversation, make sure to like and subscribe so you never miss an episode.
And we'd love to stay connected. Follow us on YouTube, Facebook, and on Instagram at In Good Company Elder Care Podcast.
You can also find us on X, formerly known as Twitter, at IGC Pod, and on TikTok at IGC Elder Care Podcast.
Thanks for tuning in to In Good Company Elder Care in Your Backyard. I'm John Ray, and I've been joined by my amazing co-host, Spencer Ernst. Special thanks to our executive producer, Alex Wallace, for helping bring this show to life. Until next time, take care, and remember, you are always in good company.